Thank you for the warm introduction. I will start the presentation. I did my thesis on time to recovery and its determinants among nutritionally at-risk infants at Gambela refugee camps in southwest Ethiopia. This would be the objective of the outline of the presentation. We'll have objectives, conceptual framework, methods and materials that we used, results and discussion, and conclusions and recommendations. So the main objective of the study was to determine the time to recovery and then its predictors or determinants among nutritionally at-risk infants which were enrolled in Gambela refugee camps. So the conceptual framework that we developed here, which actually affects time to recovery of the infants after the intervention with mommy, are socio-demographic characteristics, infant characteristics, and maternal characteristics. As you know, the study setting is in Gambela, 2 refugee camps, Kule and Terdiki refugee camps. And they were established in relation to because of the high influx of refugees from South Sudan. And one was actually established in 2013 and the other at 2016. And with that, GOL has piloted the first iteration of MAMI in these 2 refugee camps by 2016. So the study period, which is the data collection period, was from 2019 to 2024. And for this analysis, we use a retrospective cohort study design, and the source population was all infants under 6 months of age at the refugee camp during the study period. And from that, the study subjects or study population were the nutritionally at-risk infants under 6 months and their mothers. So the data collection procedures was screening was conducted once a month at the YIMCF centers by counselors, as well as outreach officers. And screening was done by EBCD approach, which was later on followed by assessment, classification, and subsequent enrollment into the mommy care based on their risk status. Then the infant's mother pairs were followed up on weekly basis, and then they were discharged once the infant has got weight gain for 2 consecutive weeks and they are no longer deemed at risk. So these were the inclusion criteria. These are more obvious criteria for breastfed infants, for non-breastfed infants. So for breastfed infants, multiple birth, low birth weight and premature, orphan, maternal conditions like if the mother is sick, unable to care for the child, maternal malnutrition, mental health problems, if the infant had feeding problem and visible wasting or recent weight loss, were the criteria. For the non-breastfed infants, all this applies, just like the breastfed infants, plus because they are on breast milk substitutes, they are the other criteria like infant without a fast source of breast milk substitutes or infants with feeding problems were included in were enrolled. So the study variables we selected, or the predictors for the outcome, which is the time to recovery of these at-risk infants, are maternal age, infant age, sex, and paternal status, and birth, multiple birth, low birth weight, premature orphan, and all these were included as predictors. And our outcome, or our main outcome, was the time to recovery of these infants. So just to clarify certain operational definitions, so infant countries are the ones which I mentioned on the inclusion criteria, like those vulnerable infants. And when we say survival status, because this is a time-dependent analysis, we are dealing with the final outcome, whether the patient has recovered or any other outcome, which we call censored, like defaulted or died or any other outcome. So that our main focus is on the event, which is the event is cured, this is the main outcome we are looking at. So the data, of course, this is a secondary data analysis. So the collection date from 2016 to 2024 was on a database, ComCare database. So we imported that to SPSS for further cleaning and coding, and then we did a descriptive analysis, and then regression analysis was conducted. So the main findings, looking at the socio-demographic characteristics, so a total of 781 mother-infant pairs were included into the study. And the mean age at admission was around 1 week, and over half of the participant infants were females. And then most of them came from a Turdiki camp, and over a third of them were self-referred. And when we look at the paternal status, 94, majority of them had fathers who were alive, and 85.3% of them had female headed households. And around 3.6% were relapse cases. And looking at the specific infant risk factors, so half of the infants were underweight with weight for HZ score less than -2. So around 48.1% of them were underweight, and a quarter of enrolled infants were reported to be multiple births, which is around 24.8, and also low birth weight also was 25.5%. And more than 1/3 of the infant mothers were reported to have breastfeeding challenges. So this is the table that shows what I have been talking about. So multiple birth, low birth weight. So these are significant findings, like low MUAC for age was found to be around 89.9%. So when we look at that, the identified maternal factors, the mean MUAC of the mothers at enrollment was 24.2%. 1 in 5 mothers, which is close to 22%, were found to be malnourished with the MUAC of less than 23 centimeter. And only few mothers had mental health issues, which is 2.8%. So when we look at the treatment outcome, over half of the participants were discharged as cured, which is around 54.5%, quite low. So by the end of the follow-up and at discharge, they are labeled as cured or defaulted or any other outcome or died. So by the end of discharge, so there are 54% of them were found to be cured. This is quite low, and so the explanation could be because of an underlying unidentified or unaddressed comorbidities, which was not recorded on the data collection. They could have congenital anomalies, chronic illness like TB, HIV that could impede the recovery despite the treatment. And over a quarter of them defaulted the program, which is 27.8, also quite high. This was seen mainly due to because of the fact that the dynamics of the refugee camp population is always moving in and out of the camps. They go back to their homeland and come back. So it makes follow-up of the infants very difficult. And sometimes these infants may have abandoned the program, and their condition could have deteriorated. Some of them could have died in the community. So we don't know their status. So the defaulter rate is quite high, which also contributes to the initial low cure rate, because we don't know their status. Over a quarter, so the median time to recovery, which is was 13 weeks. So which is quite prolonged. We can further discuss this on the discussion part, because it's difficult to compare this with the standard sphere standard, but comparing to that, it's prolonged. But since there are many possible underlying causes of growth flattening and anthropometric deficit in this age group, the management is not purely nutritional or breastfeeding support. It involves mental health and social interventions. So that might be the reason that actually extended the period of time to address this domain. So on the regression analysis, certain variables or factors were found to be predictors of recovery, like multiple births, low birth weight, infant weight loss, and low MUAC. So what it means is that, like, the finding here is infants who are of multiple birth had delayed recovery by 12.3% compared to those who are singleton. And those who are low birth weight also had delayed recovery, 22.4% compared to those who were normal birth weight. So the main reason for this is that it's known fact that multiple births compared with singletons are increased risk of premature delivery with correspondingly low birth weight. So they become premature and low birth weight and have different complications. And moreover, there is evidence that low birth weight or prematurity and other medical complications are negatively correlated with postnatal growth. The other is those infants who were reported not to have recent weight loss had a faster recovery. So obviously, this is because it usually occurs, that weight loss occurs when a child is not having adequate amount of food, adequate amount of quality and quantity of food, or frequent or prolonged illnesses. So wasting and other forms of acute malnutrition are the result of could be maternal nutrition, low birth weight, poor feeding, and care practices. So, when a child has a recent weight loss, obviously he might have a delayed recovery for these reasons. The last one is the low MUAC. The low MUAC at enrollment, specifically low MUAC for age at enrollment. Those who had a low MUAC had a slow recovery. And obviously, children with on the opposite side, who have higher MUAC, have a better nutritional status, making them more resilient to adverse effects of SAM. And the higher MUAC may have babies who have higher MUAC have a robust immune response. They could combat infections better and recover more effectively than those who have low MUAC. So it's obvious that low MUAC could contribute to delayed recovery. So in conclusion, generally speaking, the recovery rate of this infant at risk of malnutrition in the refugee camp is quite low, and the median time to recovery is slightly prolonged. And these factors like multiple births, low birth weight, weight loss, and low MUAC for age were found to be the determinants of recovery. So the final recommendation here is the recovery rate is and the prolonged time to recovery indicate that there is an aid-dependent population and additional support is required, and strategies should be developed by program managers to improve recovery rate of these infants under such fragile circumstances, which is extending the care maybe in the area if a repartition occurs. And also outreach and tracing mechanisms should be strengthened to improve the defaulter rate. And special emphasis should be given to the especially vulnerable groups like low birth weight babies, multiple births, and low MUAC, and those who have recent weight loss to improve their outcome.